in more in lecture form for orthopedics. We will be uploading some lectures also in the future, but at the moment we are giving it to a wider audience, and that's why we do it in tutorial form. And anyway, you are supposed to read a bit more from Apple's orthopedics as well as Bailey and Love orthopedic sections, and you can have an idea when you read that, and make a note about each of every condition. Your orthopedic note set should be separate. Dr. Sudhir Herat's book is also quite valuable there as a short note set, but you can add things to that. Say supracondylar fracture, you can have a separate one page, one A4 page thing note. So like that, you can keep say fracture neck of femur, the same dislocation of knee, the same small note, investigation, management options, and things like that, assessment. So you must have your own note set. You have to prepare your own note set, but you can use Dr. Herat's book and Bailey and Love chapters relevant to orthopedics, as well as these what you gather in these tutorials. So it's more of a self-study that you should be doing, because I mean, orthopedic is a vast subject. We are covering only it with 4 lectures anyway. You have to gather many things during your go in clinical training, surgical appointments, as well as orthopedic appointments. Okay, so we'll go through these things. Today we are talking about lower limbs, and we will do this MCQ and answers, which will be followed by a clinical kind of session, because you don't have any much clinical exposure during these days. We'll do clinical cases, about 10 clinical cases afterwards, briefly, mainly X-rays. So which of following are suitable management? Some people may not know other answers, but that's fine. We are going to discuss answers after this anyway. So can somebody, one person, unmute and give me these answers for leg shortening?
So we can't see the screen now.
You can't see the screen. All right.
You're not sharing the screen.
I'm not sharing the screen. Huh? Right. Let's see. Let's see. Give me a minute. It goes share screen thing. You can't see the screen yet?
No, sir, not yet.
See? Can you see now? No?
No, sir.
What about, how is it now? Hello?
Now we can see it, sir. Yes.
Now you can see it, no? Okay, sure.
Yes, sir.
Okay, right. So let's see. Okay, we'll go from there. Right. Okay. Okay, the first question, can somebody come and answer? Hello? Can you hear me?
Yes, yeah.
Okay, can somebody answer? A,
It's
which
true.
are true. B, Elisaroff, have you seen this antenna, what people call antennas? Hmm?
Yes,
Yeah, that's
yes, it's
also
true. It's a
yeah,
circular.
it's true. Sorry? Yeah.
It's a circular external fixator.
It's a circular external fixator. That's right. So it distracts the bone segments towards each other. So periosteum gets stretched and it deposits bone on the way. So rate is 1 millimeter per day, right? 1 millimeter per day. We tighten the screws. We have to keep on tightening till the bones meet. So free tissue transfer.
It's false.
It's false, yes. It would not help. Bone cannot be transferred like that, but all the soft tissues can be, but not bone. Uh, you can transfer the bone, but not in the case of leg. Okay. Do you know any other place where we do transfer bone also in a flap? When mandible is removed following malignancies and things, you have sometimes radius or piece of radius or rib can be transferred, but not in the case of lower limbs because you need stronger and bigger bones. Artificial prosthesis. Anybody? What do you think?
It's true, sir.
True. Yes, you can use it. Actually, now there are many alloys which you use instead of bone to bridge this length. And even in Sri Lanka, they are doing it. And sometimes, following in people who have bone malignancies or bony metastasis, even as temporarily, you may use metal bone for that. They show quite good results, but they have their little bit of complications, but it's fairly okay in people who are less active. And special shoes, heel races and things like that.
Yes, yes.
Yes, yeah, it is ugly. It is definitely ugly, but it is being used. Okay. So, because it's a major problem in orthopedics, the leg shortening, because almost all lower limb fractures, end up with shortened leg, right? Almost all lower limb fractures. So, but most of the time it's 1 or 2 centimeters, which doesn't need anything. 2 or 3 centimeters, it doesn't need anything doing, but there are situations you would do. What will happen if you allow a patient to walk with one short leg and one long leg? His alignment is buckled, isn't it? Because as a result, he will get back pains, early arthritis of the joints because the weight distribution is not even, right? Can somebody come and answer this one? A. Anybody?
False.
False. Yes. What is the correct answer? Skull fractures does not heal. They never heal. Okay. So when you see a fracture on a skull X-ray, you must ask the patient before attributing it to present injury whether the patient had a fracture before. Okay. So they never heal. But only thing is the old fracture around the edges of the divide of the gap you will see some thickening of the bone, but it doesn't heal. B,
True, sir.
true. Yeah, golden rule is fractures are urgent, dislocations are emergencies. Right? That's something you must remember in your life. So you never wait on a dislocation overnight to reduce. Right? Not even 6 hours, 8 hours. You must do it at the earliest opportunity. C, chance fracture is a comminuted vertebral fracture.
False.
False, yes. It is a transverse fracture. Okay, transverse fracture and high velocity. D, clay shoveler's fracture involves C7 vertebrae. Hmm? Yeah, you have these names. I told you, you must remember the names. And it happens when you shovel, clay over the shoulder. You dig, shoveling things over the shoulder. Sudden flexion of the neck movements cause this issue. C7 vertebral spine get fractured. Lower limb fractures take twice longer to heal than upper limb.
True.
True. Yeah. That's usually upper limb is how much?
3 weeks.
6 weeks.
6 weeks. Upper limb is 6 weeks, and lower limb is
12.
12 weeks. Yeah, that's fairly good. Good thing to remember that. In children, it can be little less. Okay, because children they heal they heal quickly. Right. Let's go through the answers. Okay, you can glance through the answers. Right. Regarding non-union, can somebody come and answer? A. Can somebody answer?
False, because 3 months.
Yes, but there's some definitions, they say 6 months, right? So, I mean, you can't have this hard and fast rule. We know when things are not going to work by repeated x-rays and things. So, some literature says it's 6 months. You have to wait till it's confirmed non-union. Next one, hypertrophic non-union require bone graft.
False.
False, yes. Hypertrophic non-union, you must know the two ends are hypertrophied, but bones is not uniting. So what happens is too much mobility. Bone is growing. There is no problem with growth of bone, but because mobility is more, it is not uniting. Too much mobility. So what you need is stabilization. You have to do some internal fixation or something to stabilize, then it will nicely heal. While atropic non-union, it is something else, some other problem preventing bones from growing. Okay, so that will need not only stabilization but something like bone graft or reaming, right? What is the purpose of putting a bone graft there? To heal atropic non-union. So these both B and C are wrong. So why you want to put a bone graft? What does it give? It gives osteoblasts, all these fresh tissue. Now you must have seen some soft tissue wounds also become chronic ulcers, right? There's fibrosis, unhealthy edge, margin, and it doesn't heal well. So what we do is we freshen the wound. We excise all this dead, bad tissue, and we make edges clean and fresh in our casualty, and then we do that, and then we right. Okay, right. We let it, and then it starts healing. Leads to pseudoarthrosis. Anybody?
True, sir. It's a false joint.
Yes, that's right. Exactly. It's a false joint. So what happens is there is some tissue are forming connecting the bones, and it's fibrous tissue. Avascular necrosis is a complication.
It's not always. Huh?
Is a complication. You're right. It's not always, but when you say it's a complication, even if it happens occasionally, it's something to do with English. Even if it happens English, the wording, right? Even if it occasionally, it is true. Okay, so if vascular necrosis is a complication, that's true. Like in scaphoid, it's an example. Yeah. Right. So these are the answers. Be very precise on what is underlying problem with this hypertrophic non-union and what is it with atrophic non-union. You can recognize these two on X-ray nicely, and then you can make a decision which one needs which one. Right. Malunion. Anybody? A.
False, sir.
Gunstock deformity to malunion or supranuclear fracture. It's true, really. Okay, it's true. What happens is this arm goes like that. Okay, so it will be like that. If I can show you on my video, like that. It's true. RSD.
Cubitus varus deformity. You know, sir, is it?
Sorry. We have
Cubitus varus deformities.
You know, that's so, you're right. That's also can happen. So you can have more than one deformities, right? Cubitus varus is the most common thing, but gunstock is if fracture is not reduced properly, right? But normally we reduce fracture properly, but even if you reduce, you get, as you said, the cubitus varus deformity. Even if you reduce, it's very likely to happen, because remember this always, this is something, the supracondylar fracture is always lead to malunion. Right? It always lead to malunion, and malunion can be of many different types. You can have anterior angulation of the fracture, posterior angulation. Then when you reduce and leave it, it can be either way. So this is a very serious fracture in that sense. It affects on somebody's life and later medical legal problems. Okay, and reflex sympathetic dystrophy is a complication.
False.
Sorry?
False.
RSD is a complication of a malunion. Yeah, right. It is a complication. Malunion also contribute. There are many other things which can contribute to that. Right. We discussed about what RSD before, have we? What is it due to normally? Cause is not known exactly, but there is obviously, as Wording said, there is some abnormal functioning in the sympathetic thing. So what happens is distal part get a red, swollen, warm, and it goes on for weeks and months. So aggressive physiotherapy is the answer mainly. Right? Rotational and angular deformities are better tolerated by femur than tibia. Anybody? It's true. Okay. So femur, there's a margin of error is more, right? Rotational and angular deformity, but tibia, it is much less. Varus and valgus deformities are more serious than AP angulation deformities. They are more serious, lead to early osteoarthritis. Okay. So malunion in the foot may require osteotomy. True. again, because we have to get the foot in a proper order. Otherwise, his walking will be affected. And especially in a young or middle-aged person, there's enough time in his life for this to give serious problems with walking. So foot deformities don't take lightly, especially in younger or middle-aged people. Even slightest thing you have to attend to and correct. Otherwise, they will lead to early osteoarthritis and severe disability with his walking. Okay, so this we talked about rotational and vagus and valgus deformities. You must have a fairly good idea about these things, because very often in the clinic, so in outside, you will have a person who has fracture and now he has problems. Okay, followed up in his life. So you must know what is allowed. So you can say, okay, this is accepted, this is okay. You continue with what you do, or what things need recorrection, resurgery, or prosthesis, or things, right? So in orthopedics, you must have a basic idea about what kind of deformities or what degree of deformities are accepted. So as you said, the increase in carrying angle, one of you said carrying angle in the elbow, it is accepted to an extent following supracondylar fracture. You wouldn't do anything. But when it become more serious and cause ulnar nerve problems, ulnar neuritis, tardial ulnar nerve palsy, then we correct the nerve, not the bone. We are not going to correct the bone there. But there are some situations you break the bone and do the some metal work in it. So next question, anybody? A.
False.
It's true, really. Long bone fractures, interpatellar nail is preferred because plate and screws doesn't give strength. Okay, plating and screws doesn't give strength, and also to insert that, it's you have to you expose wide area to put plates and screws. I mean, you can imagine that if you haven't seen these things in the surgery, even you can imagine. But interpatellar nail, you need X-ray guidance. X-ray guidance, and you need a small place you can insert the nail and drive in. Reaming increases the risk of embolic phenomena. Yeah, have you seen reaming being done in orthopedics? They put a drill and drill inside and drill the bone medulla, and before you insert the nail. So that way you can use, as you question C says, you can use a bigger nail. You can use a bigger nail, stronger nail. So it can be weight bearing. Like femur and tibia, it's very important to put a big one. Otherwise, if these nails break sometimes, so that's a complication you don't want to have orthopedic case. In orthopedic case, actually there is a risk of increase in embolic phenomena. Some people say it's negligible, but it's always a concern. The fat embolism and various other emboli can cause cardiorespiratory problems. They have caused cardiorespiratory problems, and something you have to monitor during this process. You have to warn the anesthetist, and they have to monitor about any sudden cardiac strain, right heart strain, things like that, because effect can be similar to pulmonary embolism. Young children are managed conservatively. Yes, in children, you try not to put metal work if possible, because that will upset their bone growth and lead to various abnormalities in their growth of the limbs. So you try your best to not to do put any metal work in. If it's really needed, you can put small K wires or some pins with low profile, but never put heavy metal inside. Intramedullary nails are not used for upper limbs. Anybody?
False.
False.
False. Yes. You use it femur, You use it in femur and sometimes in other things also, ulna also, but mainly femur. Sorry, humerus. So answers for that. So because intermedial nail is stronger and at a less chance of fatigue, loosening or delayed union. So they are good for many reasons. That's the kind of gold standard. If you can put intermedial nail, you put intermedial nails, okay? And so reaming we discussed. Children and the nails, okay. Anybody? Fracture femur?
True.
True, yes. It can bleed around 1.5 liters, even more. So it can take about, say, 40%, 30, 40% of the blood volume from one fracture femur. I always tell you, it's something which need to be taken very seriously. An isolated close fracture of femur can kill, right? Patient can present with advanced shock and kill. So you immobilize immediately and start the resuscitation, give blood products and things. So you would not, you have to be very careful with fracture femur, not like other long bone fractures or other fractures. It's the deadliest of them. B.
True.
True. So what's the reason?
Fat embolism.
Fat embolism. Yeah, this is one of the characteristic features of fat embolism is petechial fat fractures in the upper half of the body, mainly axilla. Where else you get, what are the other features you get in fat embolism?
Cerebral edema.
Sorry?
Cerebral edema.
Yeah, cerebral edema you can get, and more commonly, of
Headache,
course,
vomiting.
confusion and headache, vomiting, confusion, that is CNS symptoms. And also it can get cardiovascular symptoms like, right heart strain, and also eye. You can have some fat globules in the eye, some visual disturbances with the fundoscopy. In fat embolism, you can have in urine. If you check, you can have fat globules in the urine in fat embolism. So it's a interesting disease. What is the management of fat embolism? How do you treat it? There's chemical theory and mechanical theory regarding fat embolism. We talk about this in burns, severe soft tissue injuries, and fractures. Fat embolism is kind of common in these situations. Okay, so it's something you keep an eye on these situations. Management is basically for fat embolism supportive. You mean ABC support, yeah, ABC circulation support, central monitoring. So supportive, it will recover by itself. It can be fatal, but if you are quickly diagnosed, it can treat it, it will recover by itself. Patient might need ventilation. C. Anybody?
False.
It's false. In the middle, from your anatomy, in that area, artery is far away from the bone. What is the area where artery is very close to femur? Which part? Next to femur, bone. Popliteal artery, right? In its lower part, right? It's not superficial femoral by that stage, but after going through the adductor hiatus at the base of the popliteal fossa, it's very next to the bone. So in supracondylar fracture femur, because of the gastrocnemius pull, it turns posteriorly, the sharp edge, and there is a high risk of popliteal artery being damaged or cut. Okay, so that fracture you have to be very gentle, handle gently, and be careful of the potential arterial injury, just like dislocation of knee. D.
False.
It's true. Fracture shaft of femur, most of the time, it's intermedial nail is the best, unless it's severely comminuted or segmental. This is the thing which gives the patient strength fixation, and as a result, early mobilization. So you avoid so many other complications of being stranded in the bed. There are many complications of bedridden patients. We are not going to talk about that now, but you can avoid that by early mobilization, and intermetal nail is a key. Why you lock it is you put nails across to above and below the fracture. That will prevent rotation of the bone, or prevent rotational deformity of the femur when it's healed. E. Gallows traction is an option in the management of young children.
True. True.
True. Yes, it is. So let's go to the answers. Right. Anybody? Can someone answer?
False.
False. What is floating knee?
It's
It
because of the
happens
damage
when
of the
above
cruciate
and
ligament.
below is broken. So there is associated fractured tibia and fibula, as well as the fracture low end of femur. Then you get a floating knee, isn't it? It's not attached to either end because of breaks. Okay. B.
True.
Yes, as we discussed before, for gastrocnemius pull, and there's a risk of arterial damage. C. True, yes. What percentage of people have this bipartite patella? About 2 to 3%, okay? It's common, 2 to 3%. And most commonly, this segment of patella is, patella is the largest sesamoid bone in the body. So a piece of patella is separate at the superior and lateral corner of the patella, right? Don't misunderstand. Mistake is to for a fracture, right? Edges are fairly clean, well demarcated. So bipartite patella, it's fairly common, 2 to 3% of the people. D. It's true. Medial tibial plateau fractures are more associated with vascular and nerve injuries distal to knee. So they are more serious. So when you see the fracture of tibial plateau, if it involves medial side, you be careful. Examine these patients very carefully. Okay. E.
True.
No. Transverse fractures. Transverse fractures require tension band wiring. Transverse, and if it is displaced, okay. And comminuted fractures, you can't do that. It's several pieces together, and you have to excise the patella, and it can lead to osteoarthritis of the knee very early, because as you know, knee joint is actually two joints. One is tibiofemoral joint, and other one is patellofemoral joint. So you can have with fracture patella osteoarthritis involving patellofemoral joint. Okay. So going through the answers. So patellar fracture, if it is undisplaced, or there's no word called undisplaced. Okay, every fracture is displaced. So word is minimally displaced, right? It's as good as undisplaced. Then you would leave it, don't do anything, just put a POP cylinder, right? Straight leg, POP cylinder. It stops at the above knee, but stops at the ankle, and let the patient be in that for these 3 months, right? almost 3 months, or at least something closer. So other things, you need internal fixation. So transverse tension band wiring with figure of 8 kind of thing. And otherwise comminuted, you excise all the segments. Right. Somebody answer, please.
False.
False. What is unhappy triad? It is anterior cruciate, medial meniscus, and medial collateral ligament. It's common football injury, okay? Footballer's knee, sometimes called footballer's knee. B. Anybody? Now this is the situation here. Why patella now bone has two angles. No, our hips are wider, so the quadriceps comes like that medially, and then patellar bone is there, and patellar ligament get fixed to tibial tuberosity straight. So there is a like that from both sides, initially medially, then downwards. So a bit of a odd direction which changes on the way, right? Patellar force is like that, which you can understand. Then what keeps patella medially? Because if it's something is going like that, it always tend to move in this direction, isn't it? With the force. So what keeps patella in the center? You know the answer from Harold Ellis. There is a larger lateral condyle attachment of the medial retinacular fibers, retinacular on the medial side, and the gastrocnemius muscle, the vastus medialis, not gastrocnemius, quadriceps femoris, vastus medialis muscles also get attached from the medial to lateral to that area. So there are few factors like that keep it in place. So once it dislocates, retinacular ligament tears. Okay, but first time you must give it a go. You reduce the patella and put a POP, long leg cylinder like you put for fracture patella, and leave it for 3 or 4 weeks for soft tissue to recover. So one chance you give, just like in the dislocation of shoulder. Okay, just like in the dislocation of shoulder. You first time dislocation, you don't do anything. You immobilize for 3 weeks, which is the time which takes soft tissues to heal, and then you would not do anything. But the second time, you know that if it happens again in the shoulder, it's gone. Okay, that you have to do repair, do open surgery, so arthroscopic surgery. Same with knee. So first time dislocation of the knee, it's okay, but second time, that means patient needs surgery. Okay, so effusion 12 hours after injury is likely to contain blood.
False. Usually, hemarthrosis occurs around 6 hours.
Very good, very good. Yeah, you are right. That's the answer. D. Meniscal tears are preferably excised. They are not excised. If possible, they are repaired. Okay, they can suture arthroscopically. They are kept in play or trimmed, but you would not excise unless it's really necessary. Because if you remove meniscus or part of it, they are like washers between the two bones, femur and tibia, which bears body's entire weight. So they are very important washers or washer cushions. Okay, washers come cushions. So if you damage them, that will lead to early osteoarthritis. Yeah. E.
False.
It's true. It's true. Just because we don't have facilities and our orthopedic surgeons are lazy, we don't do that. But proper management is you repair them immediately, right? Immediately, before the inflammation starts. Before the inflammation starts, immediately and arthroscopically. Okay, immediately and arthroscopically. That's how you are supposed to repair this before inflammation starts. But it doesn't happen in here because theater times and the lack of expertise and all this set of things. But you must know the ideal management, okay? You must know the ideal management. Because in other countries, when you're working in other countries, they want referral immediately done if you're suspecting a ligament injury. Answers? Okay, next question. Can somebody answer?
True.
True. 7 is the mark. MES score, mangled extremity severity score, is a very important score for it gives objective assessment of when to do an amputation. These are medical legal. It's very important. Okay, medical legally they are very important because sometimes people can come out with these things later, much later in life when they want to claim. B.
False.
It falls. It's about 14 or 15 centimeters, okay, little longer, because it's a very commonly done thing, below knee amputation, commonly done thing. Because lower limb, we amputate at a level where good prosthesis can be attached, and below knee prostheses are very good. In fact, the best for mobilization. C.
True.
No, it is at ankle joint. It's done at the level of ankle joint. Now, this is amputation which they do in for diabetes, so whatever the foot injuries in African countries, so poor countries. We are not that poor. African countries, because they don't have money or resources to fix a prosthesis. So man can live with this amputation, and he can go to toilet and things with walking on this stump. Okay, on stump like this Long John Silver, that kind of people from Treasure Island, and so they do that. But in Sri Lanka, we have enough prosthesis, so we cut below knee, little above that, and where we can nicely fit the prosthesis and patient can function and do even farming. People are doing that. No, farming, everything with that prosthesis. D. This is re-amputation. Is you when a finger is necrosed, you don't just remove finger, you remove the distal part of metatarsal as well. Okay, that is important in diabetic. Otherwise, the wound will go up further, right? It will go up and up. So you do your re-amputation, include the part of the metatarsal as well, right? So wedge, right, where in the foot, like wedge amputation. That's the standard for diabetes. That gives the best results. Wound will heal without much problems, hopefully. Of thigh has a long posterior flap when you amputate in thigh.
True.
No, it's below knee amputation which we have a long posterior flap because you get good muscles and good blood supply there. But in thigh as well as everywhere in the upper limbs, almost everywhere in the upper limbs, you have equal mouth, equal flaps. Okay, anterior and posterior flaps, anterior and posterior flaps, they are equal, except lower leg, right? They are called fish mouth incisions. You know, fish mouth. Maluwage katawage, right? Fish mouth, nicely, two flaps. But lower leg, because posterior part of the skin is there's muscle and there's good blood flow, it heals well. So we have a long posterior flap. It's called skewed flap. Skewed flap because some people take not directly posteriorly, but tend to be more medial because there's a reason, vascular reason for to do that. Okay, can somebody come and answer?
True.
Transverse fracture is due to high energy. Yes, that's true. If you have a transverse fracture, it's high energy. Now, for example, there's a transverse fracture in, like you can have it in tibia following road traffic accidents, transverse fracture, isolated fracture in ulna following stick injury. That's called nightstick injury. So they are all due to high energy transfer. That's the indication. So you expect more soft tissue damage than in other places. Yes. B. You know what butterfly segment is in a fracture. There's a middle fracture and there's a segment like that. Butterfly segment. Yeah, it occurs on the side of injury. That's true, right? That's indication of side of injury. So when you see the X-ray, you can predict the mechanism, predict the side from that. That's why I always telling you, you have to be good detectives in judging mechanism of injury. C. Anybody? You must know about that, what Weddell's triad is, okay? Weddell's triad is when pedestrian hit by a car from the front. What happens if person is crossing the road, crossing the road, car hits him like that. And first hit, there are three places. First hit is tibia and fibula fracture. Then he falls onto the bonnet where he injures his chest and shoulder. And then he falls onto the ground, hitting his head and cervical spine and injuring them. Okay, so that's called Weddell's triad, right? So tibia and fibula, then on the chest, side of the chest and the shoulder, and then fall on the ground, head and neck. That's a typical mechanism when pedestrian hit by a car. D.
This is because of the posterior dislocation of the hip joint.
Yes, that's right. Right. When would it happen? With knee adducted or abducted?
Abducted.
Adducted.
Adducted is the answer. When knees are together, basically, when knees are together, direction is going more posteriorly, and which can break the posterior lip of acetabulum and also damage the sciatic nerve. Okay, when things are adducted. So this answer is correct. Okay, it's a common injury, so you must always look for that, and that's nasty repercussions in the future. E.
Spilon means a distal tibial fracture.
Sorry.
Pylon
Yeah,
fracture
it's a
means distal
you're
tibial
right.
fracture.
You're right. Pylon is a distal tibial fracture. Tibial articular surface, where you have articular surface fracture is from this direction, and it can have several. It get torn. The things are perpendicular to articular surface. Okay, it's a high energy fracture. Okay, right. Can somebody come and answer? Anybody?
False.
X-ray elbow dislocation. Yeah, it's false actually, because you know this up to about 4 or 5 years, slightest thing when child goes with the mother, suddenly mother push the child like that or child falls, the head of the radius comes out from the ligament because it's more sides of ligament is more horizontal like that, more vertical like that. But with adults later, after 5 years, it become more conical. So it will not easily come out. So at this thing, you know that this child has child will not move, and you ask the mechanism, you are sure there is no need to do X-ray. In fact, we must try avoid doing X-rays in young children and you don't need to do X-ray, and you do a pulled elbow maneuver, you supinate, push, and you feel a click there, and then child will move the arm. Okay, so the X-ray is not warranted. In fact, people will be angry if you X-ray with this type of people, this type of children. Okay, B.
False.
False. It's a fracture.
Acetabulum.
Acetabulum. That's right. You must know these common views. Okay, and C.
True.
Yes, C71 junction, or you can do Simmers view, demonstrate, you know, when you do like that and you have a shoot from that direction. And what is the other thing? You can do, you can pull the elbow, shoulders down and do try to get a X-ray C71. But now we have CT freely available, but still you know that these two options has to be, you must know about them. D. It's not the anterior dislocation, it's the posterior dislocation, because anterior dislocation is not difficult. You can see that easily in the AP view, APO lateral. But these special views, angular angled views are necessary because necessary in posterior dislocation, because sometimes it's difficult to see. Skyline view?
True.
True, yeah. Answers? Right. Next answer. Anybody come and answer?
True.
Is lateral quality more common? Yes, very correct. It's true. B. Ottawa ankle rules. You have different Ottawa rules, but Ottawa ankle rules and Ottawa foot rules. Okay. Ottawa ankle rules, you need to exactly palpate the tip of the medial and lateral malleolus. And then Ottawa foot, you have to palpate base of fifth metatarsal and over the navicular bone. Those are specific points, right? Tip of the two malleoli in ankle and base of the fifth metatarsal and navicular bone in foot, because these are the common sites which get injured in twisting forces of the foot and ankle, because very often this can happen. You walk around, you run and you twist and you there's swelling and you come one probably immediately, probably later, and you want to know whether this is worth X-raying. Ottawa ankle and foot rules are brought in to reduce X-rays, reduce X-raying actually, because these are very common in other countries. In Sri Lanka, for some reason, they are not that common. So reduce taking X-rays. So if you, unless you have this specific tenderness at these 4 points I mentioned, you would not do a X-ray with that mechanism, walking and twisting the foot. Okay, right. C.
So which means easy to understand, identify Jones fracture.
Sorry?
Jones fracture. That's called the base of the fifth metatarsal fracture.
Base of the fifth metatarsal, probably, yeah, Jones fracture, yes. But I am not familiar with that name, but base of the fifth metatarsal is one of the common sites to fracture, yes. So if you have tenderness there, then you do X-ray. Okay? This is only with this mechanism. But if you have fallen from height or road traffic accident or something like that, any place can get damaged. Okay, because those countries, I think people are jogging very frequently and various other small activities very frequently, and in the Western countries, so they frequently come with this ankle and foot sprain and swelling. So because A&E people have nothing to do but doing X-rays in this thing, it's like a heavy load of their time and X-ray. So they have devised these rules so that clinically you can make a decision and send most of them home with RISE. You know what RISE is, no? Rest, ice, compression, elevation. All right? Without X-ray, because if you want to X-ray, then resources, time, all that. So you must understand what is behind, why they have devised these rules. Going to see, Is Rsi injury requires open reduction.
True, as it's the main weight bearing bone.
That's right. Yeah, it's a half dome. You know, each foot is a half dome, and second metatarsal line. That line is the main weight bearing thing. And Is Rsi injury is the fracture or dislocation of the second metatarsal. So that almost always require open reduction and some metal work also. D.
Fall.
False. Yeah, walking boots are put in if there are foot fractures normally, but sprains are managed with rice. E.
It has to be second metatarsal.
Well, it is actually Morton metatarsal neuroma. Neuroma usually fourth, but it can occur in other places also. It's not a stress fracture, right? This is again due to repeated trauma. Repeated trauma like fast bowlers coming and putting the foot down firmly. Repeated trauma will lead to neuroma in one of these digital nerves. And that leads to like current-like sensation, right? Feeling current. When you walk around, suddenly when you walk on that neuroma. So management is reducing that particular activity, changing the shoes, changing the activity, and sometimes you have to do steroid injections. Neuromas need steroid injections sometimes. They can be quite difficult to treat and very problematic. So this is the answer. So what is RSI is, repetitive strain injuries. Repetitive strain injuries they can involve soft tissue, they can involve bone. When you use a certain part of your body in an unaccustomed manner or longer than you should, okay, longer than you should, or more frequently than you should. Like we see a lot of these things in garment factory workers or anyway in general manufacturing industry. Also in sports, especially in the professional sports, men and women like cricket elbow, tennis elbow, golf elbow, all these things, they play sport too much, or well, professionals. They are collectively called RSIs, so they are RSIs.
So just for clarification.
Sorry?
Just for clarification, does March fracture involve fourth one or second one?
It can involve actually anyone, right? Anyone, but I think it's fourth. But it can involve other things also like that. Although I say fourth here, that's a commonplace, but it can involve any of the sometimes third. It depends on the shape of the foot, which part is more prominent, because people have slightly abnormal shapes in different people. So anyway, you can say it's a metatarsal, but normally towards the lateral side, because medial side is more concave, give less trouble, right? But sometimes you may be right, but it can involve any of the metatarsals, all these things, right? You'll check on that later. Ankle and foot. Anybody? Can somebody answer?
True.
True, yes. Lateral malleole is very important for stability, So fractures of that make ankle joint, clearly joint mortise unstable, okay? So you have to, very often, we have to fix internally. B.
True.
True. What do you call that fracture? There's a name for that?
Bimalleolar, that is called the spots, no?
Masonry fracture. Okay. because their force goes across like that. From me, it happens in the flexion pronation and external rotation injury of the foot on the ankle joint. So you will have a fracture or ligamental damage to medial side of the ankle, and the force. Sometimes you can have opening of the ankle mortise, inferior tibial-fibular joint damage, and rupture of the interosseous membrane, and that forces get transmitted in a spiral manner and break the proximal part of the fibula, which may be neck, or because it's the weakest, or some other part. Okay, so it's a funny thing, but it's important because very often you do this X-ray of ankle because it's usually sufficient, but while examining ankle for these sprains and these fractures, you must always palpate neck of fibula, top of the fibula as well. Okay, because then you detect this particular injury. Otherwise, you are concentrating on the ankle in these things, and you forget this not so common mode of force transmission, right? So you must always suspect this, and you must, when you examine ankle, you must examine the knee in general, and particularly for this particular fracture, neck of fibula, or that area, proximal part of fibula. C.
False.
Yeah, they usually require posterior malleolar fracture, that because they associate trimalleolar injuries. They usually require no, it's unstable, only if it's unstable. Yeah, small ones does not require, but if it is unstable, or particularly if it involves the larger part of the articular surface, sometimes the posterior malleolar one, just the lip is gone, then it's okay. But if it involves the larger part of the articular surface, then you need internal fixation. Bowler's angle is used to assess severity of Patellar fractures.
False, sir. It
False.
is reduced in calcaneal
Calcaneal fracture, that's right. Bowler's angle is for calcaneal.
Angle reduced.
Sorry, angle get reduced, yes. That means calcaneal.
There is another angle also, no, sir?
Yes, there's another angle, Wessler's, or some, I can't remember that name, but Wessler's angle. So better to know these things. If you can read more, that is good, because they are common injuries, and you can take a decision on operating or leave it with the boot conservative management, which you yourself can do, or send these people to orthopedic, especially in peripheries, somewhere away. When you have to make a decision, it's important, right? You have measuring the Bowler's angle, because if you're depressed, you have to refer to orthopedics. They have to fix it internally. And of course, before that, they do CT scans, and CT scans will show the exact fracture lines and sites of segments, and then you do. So calcaneal fractures, that's how you manage. Because if you mismanage a calcaneal fracture, your whole life, your walking can get affected. So that's a serious thing. So better you do the Bowler's angle. We'll talk about that little later in our clinical thing. E. Free tissue transfer is more required in lower tibial fractures than upper. It's true, because lower tibia, as you can see your own, that's where the one part of the body where soft tissues are much less. So in lower third, particular lower third tibial fractures, you have to treat them very carefully and delicately, right? Because very little soft tissue, you try not to operate, not to do internal fixation as much as possible, but there are situations you have to operate. You try to manage them conservatively, that's the best, right? But if it's an open fracture, or it's too comminuted, you have to fix internally, then you can't do anything. Because soft tissue is less, healing is poor by naturally, and you can have infection, loosening of prosthesis. Then because of that, you will often need these flaps, okay, flaps. So middle third, you can use gastrocnemius flaps, but lower third also you can use, but it can be difficult, and you may have to put a free tissue transfer. So lower part is dangerous. answers. So Mason's fracture, you have to be careful. The widening of ankle mortise is there, unstable, and it is unstable fracture. Often have a ligament injury. Ligament injury may be inferior radioulnar joint or deltoid ligament. What is deltoid ligament? Anybody? You have forgotten the anatomy already. Huh? What is deltoid ligament? In the ankle, of the ankle? It's a basically medial ankle ligament, medial collateral ligament. Okay, medial collateral ankle it's a ligament complex. Really, it's not a single ligament. Okay, එක bones එහාට මෙහාට connect වෙනවා. So they are collectively called deltoid ligament of the ankle. It has superficial part and deep part. Superficial part connect across several bones, and the deep part connect individual bones, neighboring bones to each other. Okay, so that's a very important ligament for the stability of the ankle and walking. So it's not a single ligament; it's several collection of ligament, group of ligaments really, and which are broadly divided into superficial part and deep part. Deep part connecting individual bones, neighboring each other, and superficial part across the bones and areas. So as you can see on the E, lower third fractures, we try not to do anything, manage conservatively if we can. Anybody? Can somebody come and answer?
True.
True. Posterior injuries are serious. You are worried about them because more than 80% of the blood vessels are posteriorly, right? And bleeding is mainly B. Anybody?
Internal, external diagram, no? Yeah, internal.
True. No, it's from veins mostly, veins and capillaries. Okay, only about 10% of the bleeding are from branches of artery. Only 10% of the bleeding are from branches of artery. Okay, see, better to read through this. Tiles and Burgess classifications. There are two types of classifications. There are many actually regarding pelvic fractures, but these two classifications are the most widely used. Better to have an idea about these classifications. You don't have to remember, but if you know the names and then you can refer at least at the particular time. But no harm going through the books and see, please and see what are the principles. You can go to the internet to find these things. What are the internet, what internet says about these classifications, and what is the principle behind these classifications, right? On what basis they have classified, and what are the specific things you look at in pelvic injuries, right? Well, one thing obviously is there is a posterior fracture, posterior element or not in the injury, okay? Because posterior elements are associated with heavy bleeding. B.
True.
False, really, because open book like that, closed book like that, okay? Then closed book, you have bony spicules being driven into bladder and uterus and things, bowels, rectum, various things. So closed book, okay? Has more chance of visceral injuries. C. E.
True.
No, it is used to, it's like put across like that, or it's to stabilize the posterior fractures, not the anterior fractures, like C-clamp. You can go to the internet and see how image of C-clamps, and then they will show you that. So anterior ones are fixed with external fixators. So when we put when we put something across towel or something of the pelvic binding, it stabilizes both. But to stabilize anterior ones, normally we put pins, external fixator, and across the anterior part. And C-clamp is for posterior. These are for initial stabilization. But of course, after a few days, when patient is stable, we go for proper surgery and stabilize the pelvic ring, very often using plates and screws, various sophisticated plates and screws. Closed book fractures are also called lateral compression. So other varieties called vertical shear. Your pelvic rings are going like that. They are also serious injury, falling from height. Okay, final one before we go to clinical things. People who can't walk, fracture neck of femur is managed conservatively. True. Okay, it's true. That's how it's managed because they can't walk. No point of putting them through risks of surgery. B. Anybody?
False.
False. You know that, no? Peritoneal fractures heal well, and they can be managed with plate and screws. Doesn't require hemiarthroplasty. The cervical or subcapital fractures which completely detach the blood supply to the head and head undergo necrosis if you leave. So better to do a hemiarthroplasty. C.
True.
True. May not be visible on X-ray. So you have to think about heavily on your clinical judgment here as well. Sometimes, okay? Sometimes. D. D. DVT risk is high. Okay, DVT risk
True.
is high. Yeah, it's true. Because it's a fracture neck of femur, you patient get immobilized and they are old people. So that's absolute nightmare. DVTs. E.
True.
Yes. It's a contraindication. If you have any infection, whether it's a urinary tract infection or pneumonia or decubitus ulcer, you would not operate. You would not put metal work because there is always bacteremia or possible septicemia, and metal work can get infected. So because of that risk, they would not operate. So this is the reason why when somebody has a fracture neck of femur, you try to refer to orthopedics immediately and operate immediately, early as possible. Longer you wait, even days or weeks, you have a chance of developing some kind of infection or decubitus ulcer at least. Okay. So now we go to discuss some brief clinical cases because you are not getting enough clinical exposure these days, right? Think about what this is.
Is it open book fracture?
Okay, right. What are the abnormalities you see? What are the abnormalities you see?
Separation of the symphysis field.
Yeah, very good. So what kind of fracture is that?
Open fracture.
Open book, isn't it? Open book fracture. And what is the other abnormality? What's the other abnormality? If you look at posteriorly, what do you see?
Sacroiliac dislocation.
Which one?
Left.
Left side.
Exactly. So left, right? Sacroiliac dislocation or separation. So they like joint injury. So Here we are looking at a posterior element involvement, okay, posterior element involvement as well. So these are dangerous. Main concern is that we expect heavy bleeding, severe pelvic bleeding from this patient. Okay, so this patient might need laparotomy, probably bilateral internal ligation or packs to inside the pelvis and full damage control, resuscitation, all kind of things. So because there is a posterior element injury. Outline is immediate management. That's right. It's a proper major trauma. You need all damage control surgery, damage control resuscitation, and all the works in addition to fixing of this pelvis, initially with the external fixator here and a C-clamp for the posterior side, and later the metal proper fixation few days later when patient physiology is stable. Okay. Remember this one. Okay, a similar situation.
Close.
Right hip joint subluxation.
Sorry,
Dislocation.
Yes, that's right. So this is what we were talking about before. Typically, road traffic accident, driver or front seat passenger keeping the knees together, adducted, and posterior dislocation. We can't see any acetabular fracture, but you would expect the main concern is one is the damage to sciatic nerve, and you have to reduce these things. As I said, dislocation are emergencies, so you reduce this or even central dislocation, breaking the floor of acetabulum and going in, which happens in the case of abducted knee. So either way, you have to reduce these things and put traction on that leg, and then less pressure on this injured part. And of course, sciatic nerve injury, you have to look for here mainly the details, and you may not be able to do much about that. So that's the immediate management concerns. Reduction, traction, keep in traction, and look for nerve injury. And if there's nerve injury, you have to maintain muscle groups with physiotherapy and those things. So somebody?
Intertrochanteric fracture.
Yeah, it's a peritoneal fracture has been managed with intermedullary nail and a short intermedullary nail in this case. That is mainly to give a hold for the screws. Okay, for the screws. So what are the long-term complications of this, specific orthopedic complications? You can have, you can have break. Prosthesis can break. This can get driven in. This can get driven in to the joint and damage the joint, pelvic articular surface, and as a result, patient might need total arthroplasty in time to come. Okay, so prosthesis can break anywhere, and prosthesis can get loosened. You can have a infection of these things. Okay, so many problems can happen. Even non-union can happen even with these things. You can have non-union or malunion. So those are possible. Just like any fixation of any fracture, there are other specific things which can happen in this particular fixation. Okay. What is the main concern here?
Distal femur fracture.
Yes, we discussed about this. What is the main concern?
Bleeding.
Yes, popliteal artery injury. Very good. You can see it's turning this posteriorly. You can see this turning posteriorly. This one turning posteriorly, you can see because of the gastrocnemius pull, and so artery can get cut. Okay, and so you can see it being fixed properly, very safely, very correctly. Accurate fixation has been done. But this fixation will not give the patient the chance to mobilize weight, put weight quickly, but it will help the patient to move the knee properly. So there won't be knee stiffness, or early movement physiotherapy is possible. But this is not very strong for weight bearing, not like intramedullary nails. Okay. What is the problem here? Anybody?
Tibial plateau fracture.
That's right. Yes. Tibial plateau fracture. It's a nasty fracture, isn't it? Which side, medial or lateral?
Medial.
Medial, sir.
Medial, of course, fractured and with more displaced, but there's lateral fracture as well, isn't it? So it's both sides really, so nasty. Yeah. Lateral fracture as well, but medial is this segment is depressed. So you will need what you would need. You will need a plate here, and put screws and fix it correctly, because I told you this is an intra-articular fracture with any displacement more than 1 millimeter this way or that way, have to fix with metal work. So plate and screws, buttress plate, fold, and then screws from there will fix these things. You have to fix it fairly accurately, right? Fix these things very as possible. Okay. What do you see?
Medial malleolar fracture.
Yes. Is the X-ray adequate? We discussed about this before. You have to suspect. You have to suspect either.
Femur neck.
Sorry.
Fibula.
Yeah, fibular neck or proximal part fracture because of the spiraling force. Okay, you got to go spiral force like that, and so you have to do a full leg X-ray in this case, right? Medial injury, especially when medial malleolar fractured, you have to do a full leg X-ray. Yeah. Full lower leg X-ray, I mean. What is the problem?
Maybe calcaneal fracture, jumping.
Yes, you can see the fracture. You can see that actually, isn't it? There. You can go the line across that. And how would you make a decision to operate or not? We discussed about it before.
That depends on the
Easy
angles. The two angles.
Sorry? Which angle? Which angle? Bolus angle, isn't it? Right?
Yes.
Bolus angle. So you measure the bolus angle, and then we decide how to either it's operate or we'll manage it conservatively with a walking boot. Initially, once the swelling is gone, you will put a walking boot, because for 3 months, like this boot has to be there for about 3 months. This take low volume fracture, it takes 3 months to heal. So you have to be very careful. Otherwise, patient can have lifelong problems with the fracture. Okay. Now this is bolus angle. Go through that carefully in your mind. You can see superior tuberosity, top of the posterior facet, and anterior process tip. Above is normal and below is a depressed bolus angle, right? Normally 25 to 40 degrees. Normal angle above is 25 to 40 degrees. And if it is below that, then you are seriously thinking of internal fixation. Because it is very important to maintain the arch of the foot. As you can see, arch is so important for walking. Arch is so important for walking. Foot is a very delicate place, and walking mechanism is very complex and delicate. We don't realize it when We realize it only when we lose, so we are having problems with that following a fracture or something. What is the injury?
Neck of the first metatarsal.
If you look at the gaps between the metatarsals, do you see anything strange?
Yes,
What?
there is a bony fragment.
Sorry?
Bony fragment.
No, it's not a bony fragment. It is sesamoid bone, isn't it? Sesamoid bone in that area. Huh?
Yes.
You see a gap between the metatarsals? Wide gap.
Yes.
Yeah.
Between first and second.
Yeah, that's right. There's a gap is wide, isn't it? Actually, this base should be here. It has shifted here. So what do you
Yes.
call this?
Fracture of this.
Who's
Sorry.
Lisfranc? Yeah, Lisfranc's injury. When you say Lisfranc's injury, it's a fracture or dislocation, both or either. So anyway, this is the significance is that this affects the dome weight bearing of the half dome of the foot, and it is serious. You can't leave it alone. It needs open reduction, right? It needs open reduction and some whatever the fixation it takes. Foot anatomy has to be accurately restored. Okay, foot anatomy has to be accurately restored. What is this?
Stress fracture.
Yeah, it's a stress fracture. Yeah. That is a kind of march fracture. Okay, march fracture or stress fracture. So sometimes you may present before the after the fracture. If after fracture, that's bad. It will take a long time to heal. But this case, fracture has not occurred yet. I mean, separation of the bone has not occurred yet, but still you call it stress fracture. Patient has pain. It's not, I mean, minimally displaced. So thing is, you stop training for 3 months, right? You need to rest the foot. You may put a POP walking boot. You will rest the foot for 3 months. Then only it will heal. So you treat it just like fracture. So these are typical march fracture. It can affect, as you said, even other metatarsal. But you can see the typical appearance of callus formation and things around this fracture. Well, when you are driving a van, you know the vans don't have a front nose very much, but modern van do, but previous van didn't have. So you have both bilateral leg injuries are very common, bilateral lower leg injuries, because there is no bonnet. Bonnet protects you from injury during head-on crashes. Okay, so now it's less common, but those days you can have bilateral injury. Here it's mostly one leg, right leg, but bilateral injuries used to be common. But now with the bonneted vans, it's less of a common. Even bilateral amputations of the lower leg were common very sadly. There was a time when we had that flat vans, flat front vans. So what are the two classifications which will be useful in assessment here? Anybody? MES, Mangled Extremity Severity Score, just to decide whether it needs amputation or not. As we said, about 7 unit amputation. And other one is Gustilo classification, isn't it? Gustilo. So if you are not amputating, how to manage will be aided by Gustilo classification, class 1, 2, 3, 3 into ABC. Okay, C is vascular injury. So those two classifications are quite useful in assessment of this injury and management decision. So 10 steps in the management of this injury. Management of a compound fracture lower leg is a very common exam question and a very common clinical problem, practical problem. So you start with ABCs, only this particular injury, and then you go for broad spectrum antibiotics, tetanus, initial dressing, assessment, and then you would give analgesia and initial debridement, might need soft tissue grafts and things, external fixators may be required. And then that is immediate. And then on the long term, you have to avoid complications like osteomyelitis and mobilization, shortening of the leg, and bone migration. Bone loss may have to be treated with bone migration. So you can talk a lot about that. You have, I'm sure you have answered previous essay questions on this. We had put it forward a few times in our exams. So that's all for today. So next will be my last lecture. That will be on orthopedics, miscellaneous thing. I'll be talking about bone tumors mainly, but bone infections and a couple of other conditions in the same format. Okay, right. That's then. Any questions? Okay. Sorry?
Very beginning, we were talking about the patellar fracture. At that time,
Yes.
I used to say it is not recommended to do that tension wiring. So we have
Who said that?
Why we cannot able to consider that?
No. The thing is
There was a questions actually.
tension wiring.
The incision is the best.
Tension band wiring you can do for transverse fractures if they are
Yes.
separated, because you have to have a big.
There was a comminuted fracture.
No, comminuted you can't do tension wiring normally. No, because comminuted fracture has several small segments. Okay, for tension wiring it will be done. I don't have it. So basically you put 2 K wires across and then put this figure of 8 kind of thing, right? Comminuted, it's a several two small fragments, and as a result, it is. But as I agree with you, if you say about 3 or 4 fragments, I mean that also technically go as comminuted.
Yes.
Sorry.
That is what I really need to know, sir. That depend on the pieces of the number of pieces.
Number of pieces. No?
Fracture.
Yeah, I'm not sure exactly, because if you do this excision of patellar fragment, definitely patient is going to have problems, right? Early osteoarthritis and a lot of problems, and this happens in young people normally. So if there's any way to preserve patella, they do. So I talk to you about general principles. So I think if there are few segments only, and there's a way of getting it together, they would be doing tension band wiring. Yes, I will check that with orthopedic surgeon also.
Thank you, sir.
That sound makes sense. I mean, yeah. Okay, right. So that's it for now.
Yes, sir.
Thank you,
Okay,
sir.
Jadam.
Thank you, sir.
Jadam.
Thank you.